Hi, What the Health Tech listeners. I'm Rebecca Linley, Senior Communications Executive, and your host for this special Christmas episode. This is the podcast where we tackle some of the trending topics, ideas, and best practice in health and social care. As we wrap up the year, we're excited to bring you a festive look back at 2024's most memorable moments and inspiring insights from the podcast. This year, we've delved into everything from appreciative inquiry and governance, risk management, and LFPSE V6, to innovations in health tech, mental health, and so much more. So get cozy, grab your favourite cuppa, and join us as we celebrate another remarkable year of What the Health Tech.
This week, I'm speaking to Sarah Jane Downing. Sarah Jane has been on a campaign journey for the last 8 years following unnecessary breast surgery by Ian Patterson, who was found guilty of wounding patients with intent. You've since set up a group for your fellow survivors, which I think is absolutely amazing, kind of that turning that negativity side of it into trying to do something for absolute good and for positive change. So how have you all helped, use your own experience to try and inform this positive change for the future?
Well, you see, at the time when I found out, there had been a recall of patients in, I think, 2002, 2003. And those were the cancer patients that Ian Patterson had worked on in the NHS and at Spire Healthcare private sector. But we had absolutely no idea that the anomalies in his cancer care, because he was doing this really weird CSM procedure, which was absolutely not what anybody should have been doing ever. It was of his own invention. And so when those people were recalled, the rest of us who turned out to be the unnecessary surgery people, we had absolutely no idea, and it seemed completely unrelated. And so at the point in time when I found out in summer 2014, I spoke to a solicitor and found out that she had got a number of people who were in the same position as me, who weren't cancer survivors, but who had had surgery from Patterson that was unnecessary or wrongful or completely weird. And I very much wanted to reach out to them because I thought, we're in this really, really peculiar position and there's nobody to help us. There's nobody for us because there was a group set up that was set up for the NHS patients. But because we were private patients, we were supposed to have been told that we could join that group, but we were not. And obviously there are the cancer charities and the breast cancer charity. They had a group. But as we were not cancer survivors, we didn't think of trying to sort of join a group that wasn't, for us. And so it was very much the need of thinking, how many other people are in this really, really bizarre situation where you've just heard that all of the care that you thought was care was actually some kind of terrible other. So it was at that point that I reached out to try to get other people together, just really to see if we could share our experience and support each other. So that's how it sort of started. And I think that's the essence, really.
Something that is quite new for us as an organisation. Yeah. In fact, I'd like to say it's a world first, but I'm always nervous to say that.
No, I think it is a world first.
Yeah. Is IHI triggers, which I let you give a better description of what that actually means. But I think in terms of what it means for healthcare providers, and especially where people are integrating to those patient records. IHI triggers, so what does that mean?
I'll start with the acronym. So IHI is the Institute of Healthcare Improvement. Patient record. Within a patient record, you might have determinants of something that might have caused harm to a patient. And so the IHI element, the Institute of Healthcare Improvement, one of their processes, one of the things that they ask clinicians to do is review a certain amount of records. And within those records, they check for these indicators of harm. So a few examples might be somebody's had a long wait time in A&E, for example. And then you check that against the patient record and then you subsequently check, did that end up resulting in an incident in some way, shape or form? We're basically digitising that process where you no longer need somebody to go off and to check these individual records. we plug into the EPR record. So if you think of electronic patient record systems out there like maybe Cerner and Epic, within there, and I've got more acronyms to go through. Within there, we've got particular triggers that we can pick up on. So I'll have to read these off a piece of paper, I'm afraid, because otherwise I don't remember them. But the types of things we can plug into, so ADT, which is admission, discharge and transfer messages, ORM, which are basically lab test results, OIU, which are basically things that contain specific observations about a patient, and then RDEs, which are medication orders. So to turn those into things that actually make sense. So examples within general care, for example, might be a patient fall, a pressure ulcer, cardiac arrest, deep vein thrombosis, maybe readmission into the ICU. So somebody's been in the intensive care unit and then has gone back in within a certain period of time. Specific lab test results. So again, within this patient record, somebody's gone and maybe MRSA has been detected within that patient record. Unplanned readmissions into theatre, specific medication orders. So again, terrible pronunciation here, but naloxone, flumenzanil. So specific types of medications that are being prescribed to people. And then things within specific areas within the acute, in this particular case, so labour rooms, blood loss, lacerations, instrumental deliveries, and then emergency department, things like waiting times within ED. So interestingly, the one we're working with at the moment, which is Cerner and EHS within the Middle East, are long wait times in the ED department, and their classification of a long wait time in the ED department is actually 6 hours. So these things, these determiners, what's happening is rather than somebody having to go off and review this data, or traditionally somebody then raising an event because this ends up being an incident in some way, shape or form, we're plugging directly into the electronic patient record. We're then generating a workflow from that within Radar, which is typically a triage step, which is almost like the clinician would be doing. Has this resulted in harm in some way, shape or form? We can go a step beyond just the direct trigger though, and we can put some logic in there at the point at which the thing's generated. So those examples I gave, as you imagine, you just switch that on tomorrow and suddenly you're getting lots and lots of alerts.
So all these things they're hard-coded within the patient record?
Yes, absolutely.
And there's a reliance...
these are the message types, the triggers.
So all those messages are in there.
Yeah.
And there's currently a reliance on somebody to go in and review that information.
Which may or may not be happening.
May or may not be happening. And then once you've reviewed that, where applicable, that you would record something in an incident reporting system like Radar Healthcare to then generate and do the doing.
Yeah, so if you think of a couple of examples I gave at the top there, the patient fall and the pressure ulcer, traditionally, with a system like ours, you duplicate an effort because you're recording that in your EPR and then you're going off within your other system, hopefully Radar, to be able to raise an event, which would be the fall or the pressure ulcer. So we're just automatically picking that up, bringing the data that we need through from that patient record, triggering them with that workflow process. So one is we're actually making sure that people are reporting these things in the first place because it's coming from the EPR. And one of the things we've seen with some of the customers we've switched it on for already is there has been an increase in reporting. Just because now you're taking away that discretionary element when you say, well, actually, if this thing happens in the EPR, in the patient record, there will be an event, there will be a workflow process generated.
Obviously, there was a need for this new role. It's brand new to Radar Healthcare, so you now sit on the partnerships team. So would you be able to give us a little bit of insight into what the need was for the role and kind of day-to-day responsibilities?
Yep, so as account director, I've basically got strategic oversight over all of our accounts. So we still have our partnerships managers who they are the day-to-day contacts for all of our various customers. And then as account director, I oversee managing things like making sure that our customer satisfaction is high because we want to, keep our customers. We want everybody to be satisfied. We also want to grow. So it's also having oversight of the strategy around, how do we grow customers in terms of the product usage and kind of the opportunities there, as well as helping to see what opportunities there might be for further growth with expansion of different customers. So if we have a particular customer who's a small part of a larger group, being able to kind of hopefully manage how we can get the rest of the group on board and that sort of thing in terms of the opportunities there. And then from a personal perspective in terms of, what I liked about the role. So I mentioned that I worked in product for 2 years and I had a lot of support to get into the product role. One of the things that I
I've been really lucky to do is work across so many different aspects of Radar. So I know kind of the product inside out. I know kind of how we work and our processes. Until I went into product, I had no insight into kind of the development side of the product. It was just, it was built and it appeared.
Yeah, that's what we like to think.
Yeah, it's all the magic behind the scenes. So the product role really gave me a massive insight and understanding in the whole of the development process, and that's been really powerful in the account director role, I think, because it helps me when I'm talking with customers and also with the partnership managers and the other people in the business, trying to kind of translate how the processes behind the scenes work and actually how our development cycle works, what happens when ideas and developments are suggested, and actually how long a development piece can take, and understanding all of that and the communication of that to the customer as well has been really useful to have that insight.
So thanks for joining us this week, Marcus and Jack. And I guess, Marcus, if we can start with you, please, and just going through what you think the key differences are in advancement in version 6 LFPSC versus version 5.
Yeah, so before getting into the actual details, I think it's important to mention why we have this progression, and it's something that is going to happen over and over again, because what prompts a new version for us is, one, we have a huge backlog that we are prioritizing things. So say, for example, for V6, there is a number of things that have been prioritized to be included in this version, because now is the time to put them into production. But also, a lot of things are based or as a result of user feedback. As people have been using, they're contacting us and say, this question doesn't feel right, and those kind of things. And then we take the opportunity to revisit the feedback that we're receiving from the users. And the other thing is, when we analyze the data that we received, and then we start finding problems and things that we need to improve as well. So those three factors kind of come together when we're planning the release of a new version. So for V6 specifically, we have the M&D. So we're bringing together the kind of the coding of medicines. So it's supposed to be medicines and device, but we are relying, or is more reliable, the information we get on medicines, and that's what we are rolling out at the moment. So this is one new thing that's being introduced in this version. The other thing is that is part of this release, but can be done with V6. There is a deletion of records.
Yeah.
So there's another functionality that has been rolled out within the V6. So users will be able to delete incidents that they believe do not meet the LFPSC requirements and have been submitted as an error. We received, when we looking at the data that we received a lot of test records. And we're making this available so the user can go and clear those incidents from their kind of that data.
Yeah.
And a main key thing is the supporting questions for PSURF. So we've been rolling out the PSURF. So we need to also put the LFPSC into context. That is not just the tool, but this is part of the patient safety strategy. And there are other parts of that strategy, and we all kind of supporting all those moving pieces. And one big part of the strategy is the PSURF, is the new serious incident response framework. And V6 has the questions and the workflows to support trusts to then make better use of that and start doing the transition into PSURF, and that will enable the retirement of STIs system, because one of the goals that from the beginning was to unify those systems and have a single port of data collection. And to do that, we need to have the questions embedded in an LFPSC taxonomy that will enable the replacement of or the decommissioning of STIs. So those are the kind of key points there. And in terms of the feedback that we received, things like specialty, service type updates, incident location lists, those all have been reviewed. People's actions, wording on questions and help. So all of this has been adjusted and has been rolled out as part of V6.
I'm going to be joined by Rebecca Linley, Senior Communications Executive at Radar Healthcare. In this podcast, we're going to be tackling social media, what this means within health and social care, also some trending ideas and best practice around this subject. So, welcome, Rebecca, and thank you very much for joining us.
Thank you for having me.
Can you start by telling us a little bit about social media and the impact that this can have on the sector?
Yeah, definitely. So there's so much positive that social media can bring to health and social care organisations. So to put this into context, there's nearly 5 billion people worldwide using social media at the moment, which is 62% of the population. So obviously by being on social media, you're so much more accessible to your audience. People can find you a lot more easily. Obviously, social media at the minute is being used heavily as a search engine. I know I do this regularly when I'm even looking for holidays or anything like that. I will go on social media and look at people's reviews on social media because I think you connect from a person to a person. It's almost like you trust that review a little bit more because you can see that person talking about that hotel or so on and so forth. So obviously social media is a great marketing tool that can help you connect with your audiences, whether that be through posting, engagement, instant messaging, all those kind of things. We recently attended the Care Show London, and one of the sessions there was basically talking about social media and how it can be like the shop window to your organisation. And I think that is so true because it gives you a perfect opportunity to highlight all the positive and good things that you're doing in your organisation. Within health and social care, as we know, there is a lot of negativity within the media and stuff like that. So having this opportunity as an outlet to showcase all the positive things that you're doing within your organisation to your audience, not only is good for your brand, but helps reassure the people that have trusted within your service. So, for example, loved ones' residents could be in your organisation. So although your target audience might not necessarily be on these platforms, people connected to them will be, and they will be following along to see the things that you're getting up to and that kind of stuff. And then more on that, obviously social media is such a good opportunity to be able to network with the right kind of people, like-minded people. We do it all the time through LinkedIn. We'll connect with different people. So for example, a lot of our guests are found through social media. So one of our recent guests, a patient safety expert and nurse, Linda, was on recently talking about empowering nurses. She has a really huge following on LinkedIn, Instagram and X, and that's essentially how we found her. She posts so many influential videos, educational videos to spread awareness. There's so many influential people like Linda on there that are sharing educational videos. And that's another resource that you can use social media for. Something that we do, especially at Radar Healthcare within our marketing team, is we dedicate time to scroll through content, looking at our partners, looking at just what's happening within the industry. It's a great tool to help you stay on top of what's going on, because obviously so many people are on there, so many people are posting about trending topics and topical things that are happening within the industry. So yeah, it's a really good resource to get information and be reactive to that information.
What is appreciative inquiry? That provides a perfect segue into that. Because actually what it is, it's a heart set and it's a mindset. And it's a way of looking at the world through a generative kind of set of eyes rather than a kind of negative deficit-based focus. So traditionally and biologically as human beings, our brains are set up to always be looking for the danger that's out there. It's the natural kind of human way of being. It's part of our limbic system, that kind of pre-evolutionary part of our brain that says you need to be looking over your shoulder constantly because the saber-toothed tiger might come and get you, or the other tribe of Stone Age people might be about to club your back of your head in. And our brains haven't evolved from our limbic system to that point where we naturally recognize that we are the apex kind of predator now. We don't need to worry about being preyed on by others. And our brains haven't quite caught up with that. So appreciative inquiry is a way to help our brains to catch up with that different kind of place that we've got in the world, and to help us to recognize that if we always look for the negative, which is what we kind of traditionally as human beings do, we'll always find the negative, and you'll always be able to find the negative in any situation. Whereas if we switch the way that we look at the world and we start to try and find what is good, what already exists that we can grow on, and what can we make even better, it helps our brains to switch into that place where we can look with a more generative focus and start to ask the questions that help us to kind of really rapidly move forwards with improvement and with developing change ideas, because we're coming from a place of what can I grow from rather than what's wrong. So we talk about what's strong, not what's wrong. And I think that's a really kind of key message of appreciative inquiry. So yeah, whilst there are tools and techniques that you can use, it's not a set of tools and techniques. It's a way of looking at the world and a way of thinking differently and a way of accessing the good that is already there.
I think that's so interesting.
Because otherwise,
I think. Do you know what? I think that was a really condensed way of talking about it. Because, like you said, you could talk about stuff like this for so long, and I think that aspect that it's not just, you mentioned at the beginning about it's impacted your whole entire life. It's not just your work bit, and I think that's so interesting in terms of how you do view the world, and kind of how you do kind of view the day-to-day stuff, as well as then how important searching for the good is within the healthcare settings as well.
Yeah, definitely. I think we've had years and years of being told that the NHS is broken and it's unfixable. And actually, from all my experience, and I'm sure Katie will agree from all her experience as well, yes, there's bits of the NHS that absolutely could be better, but the NHS is not broken because the people in the NHS are passionate and want to do the best. And while that's still the case, the NHS will never be truly broken, I don't think. And if we look at what's going really, really well, then we can help people to move forwards to a space where they can make that thrive and really bring that joy in work for themselves and for patients as well.
So we kind of touched on it. Which features do you think the customers have been the most impressed with? So obviously we've just raved about it for 5 minutes.
Like we would?
Yeah. You would hope so. What do you think people have been impressed with in terms of the things that they couldn't do before with the old version?
So I think the approval side of things, which I know we've already talked around, but actually, especially those organisations who were using the risk register before the development. So we've had a mix in the beta group. So we had some people who are brand new to Radar and never used the older version, and they were waiting for this development. And then we had people who were on the older version and kind of had some challenges. So yeah, being able to kind of track and see what risks actually make it onto the risk register as approved risks. So that's been a really, really key feature. And then some of the assurance stuff as well, being able to track actually whether it's a strategic risk or not. Just because it's an organisation risk doesn't mean it's strategic, and being able to track against the objectives. But the key thing, I think, is the analytics. And I
was going to say that.
Yeah, sorry. Yeah, the analytics, being able to kind of track the trend of risk scores over time, being able to track escalation. So people have sometimes been a little bit blind, even if you're doing it in an Excel document, how do you really track the escalation of risk, and how do you track any kind of alerts that go off the back of that, and being able to notify people. So escalation by score, escalation by scope as well, and kind of other changes within there.
And just, the amount of effort that goes into producing all those reports that people were doing and things like that, you just kind of got, well, all of that
Yeah.
You know,
And
it goes because you just use the analytics.
And it's such a small thing, but we did a webinar recently, like highlighting some of the analytics dashboards, and one of them was just like simply like the average target score versus the average score versus your target score, and actually that was just one chart where it was super easy to see. And like straight away, you've just got the data there, and in a visual, so you're not having to like kind of think too much about what you're looking at. You can straight away see, and like just really small things that you can do in the analytics that save so much.
That's a good example, because again, that's us learning from our customers, because that design came from one of our customers building out a dashboard on risk, and we were like, well, yeah, that's really great. Can we share that idea?
Yeah.
And then we've used it in our own dashboards.
Yeah, and that comes into like the partnership approach with all of this in all of our development, doesn't it?
Absolutely.
The Academy was designed to provide 24/7 training access, really. What was very clear was a lot of training is about the how. How do I do X? How do I do Y? Then the next level of training is, okay, but what does that mean to us? And
putting it in practice.
And putting it in practice. And if by putting it online 24/7, it meant anyone can upskill on Radar really quickly at a time that suits them, because we all know how busy everybody is. So a 9 to 5 is not always the easiest time to get that training in. So you can do that whenever you want. You can also have copies of that training for your own LMS to train your staff, because again, you've got to roll out, you have to train 1,000 people on how to use a new online system, and it's relatively straightforward, but you want to be able to provide additional assistance at any point where you can have that fully available.
But also as well, like just to have it in the background. If you're like, oh, how do I upload an incident again? I've got it there. It's not like you're relying on someone to be like, oh, Rob, how do I do this? You've almost got that system ready to go. Just go through the little course again, and then you're, that's how I did it.
Absolutely. I mean, that is, everyone's different. Everyone has different learning styles. But for me, I'm kind of an in the moment kind of person, but I like to work through things in a sequence. So I find training and e-learning really helpful, because I'll go back to that course, I'll go to that point in the course, and I can work my way through it, and it's like, oh, okay, it's like a story. I like, that's the point I got to.
It's also reassurance as well, isn't it? You might know it, I don't know, 90%, but because obviously in healthcare there's quite a lot of complications and stuff like that. You want to make sure you're submitting something right.
Yes.
So it's 100%. Having that in the background, working on it at the same time almost.
Yeah.
So then you know that you're doing it right.
Absolutely. And then for other people, it's more like, I just want a quick guidance. We've got our community. Or some people, I want to ask a question. Again, we've got our community, or you can get in touch with us. For some people, it might be then the extra level. So as I said, what I found was particularly, we got all that set up, and then I went on leave for a while as I became a dad. And then when I came back, actually, a lot of feedback was really positive about the Academy. People were, it really suited some people's learning styles, and they were really getting on, and people finding it really helpful. The conversation had changed, training conversation had changed to be, okay, we get it, but I really want to explore what this means for us, or I really want to explore new avenues, or I didn't know it could do that. Level. Where do we go from here? And I think that's really where this consultancy piece comes in, because that training piece had morphed a little bit into a conversation, into scoping out exactly what is it you need and the support you need to do it, and we'll get you there. So tailoring and making sure everything's accessible and easy to get in hold of is really important. And we know we've got work we can increase on there. So the great thing about having all these things is that they're all available 24/7. The downside to all these things is you've got a lot of websites. So we are really aware of that. And this is complete transparency. We know we've got an online academy of all our training. We know we've got a community. We know we've got a support desk. We know we've got websites. So we know that there's a lot of websites at the moment. And that's something we will be looking at going forward is, right, okay, at the moment we've got all these things, which is great, and it really meets people's needs. How do we make them more accessible by bringing it all in? And it probably goes back to single sign-on, doesn't it?
Nice natural loop that we've just done there. And I think as well, like the Academy, for example, it has kind of started to do that, hasn't it? Like I know that my version of the Academy has like the community links and things like that. So there is.
We've tried where we can, in where we currently are. So we put in links to each other, so they link out throughout the e-learning. Rather than the e-learning telling you every single aspect of something and minutiae detail, actually, if there's something that goes into more detail on the community, we'll link out to it, because it's like further reading, essentially. I think we actually call it that. And it's like, for further reading, we link out to the community. So it is an ecosystem, and it's really important they all sort of speak to each other and they all interlink. And we'll be continuing with that, because they all support each other and they'll have their own specific purposes.
Okay, so let's start at the very beginning. Can you tell us, first and foremost, what the Anglian Community Trust is, how it came about, and a little bit more about the mission behind it?
It's quite an odd beginning to a certain extent, because it actually started as a social enterprise, or should I say a social enterprise existed called Anglian Community Enterprise. And basically what it did was community care. So, for example, your nurses that go out to patients, physiotherapy at home. We also had community hospitals, things like that. Had about 1,500 staff. And over the years, what it did was any money that came in from the NHS, basically we didn't really make profit. What it did instead was go into a fund that could then be given to a charitable part of our organisation and be reinvested back into the community. Hence why Anglian Community Trust got formed. It got formed while Anglian Community Enterprise still existed. Much easier way of saying it is ACT, in truth, because it does get a bit of a mouthful saying the whole thing. But what happened was the Anglian Community Enterprise closed in 2021, and basically ACT kept going. And the main thing was the question was asked of staff, what do you want to see happen to ACT? What do you want to see doing? And the biggest thing was we want a legacy for what the staff achieved over those 10 years of Anglian Community Enterprise. So ACT continued, come up with that very clear aim that we have. And they wanted to see that local charities, small local groups, startups, things like that would have somewhere to go to kind of get some funding from us and continue into the future. So not be kind of a short blast in a pan, but kind of a nice ongoing charitable organisation. So that's kind of where we come from. And at the moment we focus primarily on North East Essex and the surrounding area. But in the future, you just, like with everything, you don't know. It could be a lot bigger in the future.
Brilliant. I like that there's a growth plan there in the blue sky thinking's always good.
Exactly. You never know.
Exactly. You've obviously worked in healthcare for a number of years. So has your background in the industry helped what you support what you do at ACT?
Yeah, I think the biggest thing was I did used to work for ACE, which is a big thing, so Anglian Community Enterprise, doing quite a similar role to what I do for St Nicholas Hospice Care now. And in truth, when I got involved with ACT, I was actually kind of asked, would you be interested in being a trustee? Because they were actually looking for people that used to be part of it to kind of guide it in the right direction that staff would have wanted it to go in. And I think it was only about a year and a bit that then I ended up being the chair of the organisation, which I'd hope to say is because purely they thought, I think he is a good person to take us into the future. That's what I think in my own head anyway. Quite quickly we started putting plans together, and we realised quite early on that we had to really focus on social care, mental health, physical well-being of the area, and organisations that sometimes wouldn't necessarily be given a chance to get charitable money, which is a big thing with us. So sometimes you might have an organisation say, we need X amount of money to do this project. They won't necessarily get very far because they're a new charity, or it's a new project, or it's something that's not been heard of before. And sometimes just them being associated with a charity like ours then opens more doors for them as it goes on. So from that point of view, because I worked in healthcare, I was now probably about over 22 years in healthcare environments. I think what it's done is meant that I know quite a bit about healthcare, the social side of things, mental health, and the physical side of things. I've seen the commissioning side of it, and I've also seen the provider, so the forefront of it as well. So both of those things going into this has meant that when projects do come through, we're looking at something. I kind of would like to say that the experience I've had in the past means that I know whether something's a good or a bad thing to follow up, and what we need to ask to see if it is going to be successful or not. So, lack of a better example, yes, we'll provide X amount of money for you to do this, but what we'd like back is to know how you're going to measure it successful. So has it reached all the teenagers you expected? Has it helped GP surgeries reduce their waiting times? Has it reached out to the mental health people that you wanted to? The reason for that is then we can say to other people that want to provide money, look how successful this project was, provide money for them. So we almost try to look at ourselves more of almost like the startup charity for people. So I think the knowledge and skill that come from that is useful. And we also have a local counsellor that's on the board that was previously the chair. We have the chief exec from Anglian Community Enterprise that's the treasurer, so still involved. We have another trustee that actually is the chief exec of another local organisation called Yes, and we have another person that used to work for Anglian Community Enterprise as another trustee. So we have a really nice, quite a good open lot of people there that have lots of knowledge of the community, lots of knowledge of healthcare, and lots of knowledge of governance as well. So it's quite a nice group we've got, and we're quite small, so we're small enough to get things done quite quickly.
So after 2 seasons, 68 episodes and 75 guests, I think the listeners would like to know what inspired you to start What the HealthTech?
So the reason for starting What the HealthTech was around, we wanted to create a platform where we could bring health and social care, the industry, together a little bit, and speak to industry experts, speak to different people across the wider industry, and basically be able to create somewhere where people could share challenges, they could share best practice, they could share knowledge, they could share expertise. There's obviously such a wide spectrum across health and social care, and there's so much negative press as well, that, you know, whenever it's in the media, it's always something negative. It's so rarely positive. And we knew from talking to our partners that there's so much positivity across health and social care, but it never really gets shared. There's people that work in the industry that do amazing things every single day, that if we could share that a little bit or find a way to do it, that they may be able to kind of inspire other people in the industry as well to do similar things. So, you know, somebody might have implemented something in a care home, for example, that's a really simple thing to do, but, you know, nobody else knows about it. So by sharing these stories and sharing what people are up to, it should basically, or we hoped that, you know, we might be able to elevate the standard of care that is happening right across the UK and the world, really, because we've got international listeners as well, which is fantastic.
And that's the end of the podcast. Thank you to all our incredible guests, viewers and listeners. We are truly grateful for your support and engagement throughout this year. We can't wait to return in January 2025 with fresh new content. And don't forget to rate and subscribe. And if you have any questions for us or our guests, please email whatthehealthtech@radarhealthcare.com. From all of us at Radar Healthcare, we wish you a Merry Christmas and a Happy New Year.